The average size of tumor in Indian female is around 3.5 centimeter. If you do self-examination, one can reach to the 1.5 centimeter, half of the size.
And that's literally early diagnosis.
Absolutely.
The patient needs to understand that once he's a cancer patient, he's always a patient.
You discover a lump,
Right.
and you say to yourself, I will have it examined at my next annual checkup.
Right.
That is still too late.
People will be surprised to know most of the head neck cancers are almost 90 to 95% curable if detected early. They go to Ayurvedic or other form of medicines, they try to take other herbs, and ultimately they waste a lot of time. So early stage tumor, which could have been caught at T1, now it's T3 or T4. We are becoming a capital of diabetes. We are becoming a capital of hypertension, obesity, all diseases.
Now, this is not something you're born with. These are lifestyle
Absolutely.
diseases.
These are the 4 or 5 signs which a body gives hint, right? If you pick up early, these are the sign of cancer.
Hi, I'm Jagu. Welcome to the Good Doctors podcast by Zynova Shalby Hospital. Cancer is a word that instantly creates fear. But information changes fear into action. Today we're discussing 2 of the most common cancers in our country, head and neck cancer and breast cancer. What causes them, how early detection changes outcomes, and how treatment has evolved with modern technology. Joining us are Dr. Deepak Khanna and Dr. Sandip Bipte, leading surgical oncologists who will help us understand what we must not ignore, what we must screen for, and most importantly, why is there more hope today than ever before? If awareness can save even one life, this conversation matters. Dr. Bipte, Dr. Khanna, thank you so much for doing this with us. When we talk in terms of hospitals or admissions or just medical terminology, cancer, for better or for worse, sometimes has top of mind recall. So what I'm hoping we can do here is that take certain areas of that unfortunate disease, as it were, and sort of break it down to layman terms so that we can understand it better and we can look towards prevention, cure in a more intelligent way, as it were. So, Dr. Khanna, let me come to you. Cancer, creates an immediate fear, but then the flip side of it is that awareness changes outcomes. I want to get into head and neck cancer. People don't fully understand what that includes. Can you explain to us what areas are affected and how is it that it is one of the most prevalent in the country today?
Thank you for inviting both of us. So basically, head neck tumors are all the tumors that occur in and around head and neck area. So when you're talking about head neck areas, we are talking about mouth, which is your oral cavity. You have multiple glands, salivary glands in and around that. You have got scalp, you have eyelid orbits, you have got glands in the center of the neck like a thyroid and parathyroid glands. So tumors occurring in this area all around are known as head and neck tumors.
Okay.
So you have multiple subsites from where these cancers, plus the vocal cords, of course, the larynx. So in and around these areas, each subsite can cause a tumor to develop, and each site for that matter is treated in a very, very different and a specific way.
I see.
So why India is kind of a capital for head neck tumors is because of the availability of products which can cause cancers, habitual patterns, behavior patterns for people consuming these kind of products which are available very, very frequently and almost everywhere.
Is this the obvious ones, or are we looking beyond that? Tobacco, alcohol?
Yeah, these are the
betel nut?
most obvious ones.
Okay.
These are the most obvious ones. And the behavior patterns in our country has changed recently. So we are kind of exercising less. We are eating more of processed food. All these ultimately are resulting in the numbers going higher and higher.
Fair.
And the stress, of course, stress is one of the most important, not the direct cause, but because of stress, people are consuming more and more alcohol and more tobacco-related products because they find a kind of freeway or a space so that they can relax themselves.
Yes.
Even in our parties and all, nowadays we observe even very young people who have just 18 or even before 18 years are consuming smokes and cigarettes very oftenly and openly.
Fair.
And this has resulted in the numbers going very, very high, basically.
I understand. And Dr. Bipte, when it comes to breast cancer, awareness has grown.
Absolutely.
Confusion still exists at some level. how early can one spot signs?
So
And
this-
what is the awareness that is needed for that?
So let me thank you for this wonderful conversation. So I think it's a very pretty important question, how we can early detect, because a lot of patient आते हैं कि मुझे कैंसर पता ही नहीं था, मैं तो 1 महीने पहले नॉर्मल थी, अभी पता चला है. It's a very common symptom. So today's world, everyone is so busy that they don't have time to examine themselves. First thing, if you say metros and the rural area, so the women are so busy here, they don't have time to examine the breast. And
that's the important
that's
thing.
the important thing.
Examine themselves. It's not even a medical test.
It just take a 1 minute of your time. If you examine 1 month, the average size of tumor in Indian female is around 3.5 centimeter. If you do examination, self-examination, one can reach to the 1.5 centimeter, half of the size.
And that's literally early diagnosis.
Absolutely. When you talk about early, that's the key word. You need to examine yourself.
Fair. I want to come back to lifestyle habits. They're widespread and, well, getting wider, as it were. What are the early warning signs that we should look at over there? The risk factors we're aware of, it's literally printed on packages, as it were.
Yeah.
But say the risk has been taken, and sometimes it's simply environmental risk. What are the early warning signs in head and neck cancers?
So for oral cancer, especially if you have a non-healing ulcer which has developed and it's not going for say 3 to 4 weeks, it's not healing, and you go to your general practitioner and he gives you some multivitamins, some topical ointments to be put on that. Still the ulcer doesn't heal. For that matter, it increases in size. This is not a normal ulcer. This needs a further investigation, mostly a biopsy by a qualified surgeon who will come to the practice or a hospital and take a small tissue of that ulcer, and we'll examine under microscope. What cells are we looking at? So usually ulcers which don't heal for 3 to 4, unless the patient has a systemic issue, is a HIV positive patient, or has he's on immunosuppressive drugs, or has been chronically ill because of many other diseases, has got chronic uncontrolled diabetes. That time the biopsies can come as negative, but more often than not, if it's a healthy person who has got hardly any comorbidities and develops a non-healing ulcer which does not heal, I'm talking in respect to oral cancers, then this is the warning sign and this needs to be further investigated.
Okay. Signs for other cancers, because you mentioned so many subsites.
Exactly. So for voice box cancers and for upper cervical esophagus cancers, so difficulty in swallowing. Okay. And for oropharynx, which is a part of the oral and pharyngeal area, which is your mouth and behind the area where you have your tonsils, your base of tongue, all these areas. And the pharynx, which is the posterior backside wall of your throat, basically. So you will have middle ear pain. Again, you will have little bit change of voice. We call it as a hot potato voice. If somebody keeps a potato on your tongue and the way you speak, so you are speaking in a very different way. So difficulty in swallowing, difficulty in speaking, hoarseness of voice when we are talking about voice box tumors. Because see, a normal way, if the patient is having common cold and whatever laryngitis or pharyngitis, it usually goes off in a week or 2 or max in 3 weeks, even if it's very, very severe. But if the symptoms of hoarseness are not going for a month or 2, it needs a further investigation. It needs to be evaluated by what we call as indirect laryngoscopy, where you put a scope inside and look at the movements of the vocal cords. Not only the vocal cords, everything above the vocal cords and below the vocal cords. And more often than not, we do find some very, very unfortunate, kind of lesions lying silently without telling patients anything. And one more very important symptom in these patients is pain, bilateral or unilateral to the middle ear. If you have a ear pain, which is not going. So these patients usually have a tongue-based tumor, or a tonsillar cancer because of the nerve interconnections between different nerves supplying different areas. Then we have nasopharyngeal cancers, where patients which are cancers behind your nose, basically. These patients will have difficulty in breathing, will have an episode of epistaxis, they will have obstruction of the nose. And I mean, we are very much shocked most of the time that most of our ENT colleagues, which are very, very good in their work, kind of don't, kind of put a scope and see behind, where they treat them as normal deviations of nasal septum or just a polyp, enlarged polyp or something, where the tumor is lying just behind it. And it's a huge mass, and which has been missed by multiple doctors. And because we deal with these tumors quite often, we first rule out cancer. I mean, Sandip will agree to me.
Yeah,
we want to rule out cancer first, and then other people can treat whatever is there. Because if we miss that cancer, which is hiding behind your nose, which is not an area where you can look at,
absolutely,
patient is going to definitely, God forbid, die very, very soon.
Unfortunately.
So these are very common signs and symptoms. And the best part about head, neck, and breast cancers, these are the cancers which you can see.
I agree.
All the cancers in the body, when you're talking about GI, lung, esophagus, liver, you can't see them. By the time you diagnose them, they have already very, very advanced stage, unfortunately. So we say it is the best cancer to have because you can see it. If you pick it up early,
you can treat early.
And it's the worst cancer to treat because if you come late and you have a huge mass in your mouth or in your thyroid and the huge swelling in your neck and you do nothing about it, it's going to trouble you like anything, and even trouble us for that matter.
True. I want to, Dr. Bipte, get to that point that Dr. Khanna made, that this is something that you can see.
Absolutely.
But you could probably see a patient and tell immediately, even before a test has been conducted.
Absolutely.
But for a patient, say in breast cancer, who's dealing with this for the first time,
right,
a lump could be a wound, some sort of fibroid, a discomfort, as it were.
Right.
Where is the point where a patient says, I need to see a doctor?
Yeah, I think it's a very valid and important question for our audience, because I need to differentiate between, am I dealing with cancer or no, right? Whether my lump is cancerous or no. That fear, every woman gets feared, oh, is this cancer? When they examine, and that goes. So anything hard lump in the breast, which is recent onset, we call it, अभी कुछ एक महीने से मुझे कुछ गार्ड महसूस हो रही है जो हार्ड है, that's an important the warning sign. Sometimes some women will have a nipple discharge. Every woman will have a nipple discharge, but a blood-stained nipple discharge, that's an alarming sign. Blood-stained nipple discharge, don't treat at home, right? Third thing, the ladies might say, my one nipple is going up, one is below, right? Something is pulling inside, we call it retraction. That's another sign of breast cancer. And fourth is most important is the breast get changed like a PD orange, orange ka silka kaise hota hai, sandre ka chilka, dot. And that's an advanced stage of cancer. So these are the 4 or 5 signs which a body gives hint, right? If you pick up early, these are the sign of cancer. Apart from that, the nipple discharge, this soft lump, fibroadenoma, they are the common sign. But I always say, make an effort to go to doctor, examine yourself. Don't be your own doctor, because in most of the time, small lump, it's very difficult to find for us also, whether they are cancerous. So the best take-home message for all the audience is, whenever you notice lump, examine yourself, go to the expert and recheck with them. That's the best thing to do it.
I want to discuss a small timing matter with you.
Right.
You discover a lump.
Right.
And you say to yourself, I will have it examined at my next annual checkup.
Right.
That is still too late.
So it's absolutely late. So a lot of women, they will think, मेरे periods आने वाले हैं, I have a lot of cysts in the breast, ये हमेशा आते हैं. So when you examine yourself, oh, this was last time, it was there. So this is normal lump, right? So do not ignore it. The best thing is to that 1 year is a longer time. So as soon as you notice, most of the lump, they disappear with the periods, if it related to normal periods, right? If it persists more than a month's time, one should see the expert then.
Fair.
Yeah.
Okay. That's a valid time.
That valid time. And it's not delay in 1 month time. If it's not subside, just go and check. Because we have the lot of myth in the fight. मुझे कैंसर नहीं हो सकता है, ये गठान फाइब्रॉइड की है, ये सादे दूध की गठान है, all these symptoms we had listening from them.
Yes.
And I do see a lot of women with this symptom coming to me as a breast cancer.
Wow. Okay.
So it's always better to have examined with the expert. That's the key.
Fair.
Yeah.
Dr. Khanna, from an early detection point of view, if we're coming to head and neck cancers, how does early detection change the prognosis?
So, I mean, people will be surprised to know most of the head neck cancers are almost 90 to 95% curable if detected early. So again, unfortunately, in our country, we don't run early detection programs like it's in UK and US, So if you can pick them up before they actually cross a very initial T1 stage or even a pre-cancerous stage where they come as soft white or, red patches in the mouth, where they just require a laser surgery, or even without surgery, they can be observed over a period of months. These lesions will not develop into cancer. But unfortunately, what I think I'm sure Dr. Sandip will also agree, most of the patients we treat, they come to us in stage 3 and 4 and above.
It's fairly advanced.
Very advanced.
But this is coming from lack of knowledge or lack of acceptance?
So
both.
I think both. And it's very sad in breast cancer, the 50% cancer come in stage 3. Can you imagine, stage 3? How much best you do, they're going to have some issues. What you rightly said, we always happy when you see cancer at early stage. What early stage? It localized. बस वहां पे है. It's not spread to the surrounding tissue, lymph node, and we always happy. Arey, your cancer is not spread.
It's isolated.
Isolated, localized. Just do local treatment and we'll be fine. That's where the surgeons, I think Dr. Deepak will be happy when you see a small cancer, and when you see advanced cancer, we always think of future. Oh, it's going to be advanced, going to come back. We don't want to see that stage. But I think the things are improving much more here because of a lot of the awareness happening. So the people are coming with, especially in the early cancer. I do see cancer on mammogram. Means they don't palpate. I say, and so when they come, doc, I don't have symptom. I just went a routine checkup. I could see the cancer on mammogram. And that's we wanted to see early because they are less than centimeter and curable.
Okay.
So that's help for screening and how we can detect cancer in early stage.
And I want to come to that topic of screening, as a matter of fact, Dr. Bipte, because there is some confusion about what age screening should start at. So what is the correct age?
Correct. So I think this is important. General screening is to start a cell breast examination.
Okay.
We should taught, because I personally believe they should taught in the school age when the girls are 7 and 8 standard. When you teach them about the examination, when they become 12 standard, whole country will be ready to examine themselves, right? At the first step.
Okay, just start the whole process of awareness.
Yeah.
Okay.
But when they reach 18, 20, when the breast size develop fully, they should examine once in a month. Self-examination. Okay. And once you examine every monthly, you will be master of your own breast to know what's happening, right? If something new, and then you can go and check with the doctor. This is a breast cell examination.
So even if nothing is happening, you've created your benchmark.
Yes,
so that if something abnormal is there,
Yes, that's a landmark where you have to go. Second thing we call as screening. If I notice something, what you do? Then we always say go to doctor and he examine you, and if he feels sonography and mammography, right?
Sure.
Generally, sonography is a test which you look for younger women. A mammography we do for a age more than 45, 47. That's a test, right? We don't recommend mammography for a younger population because the breasts are dense, so it doesn't solve the purpose. But if sonography pick up something, then we may do mammography also.
Okay, fair. And so self-screening, early age, late teens onwards.
Absolutely.
At least be aware, learn how to do it.
Correct.
And then leave the testing beyond that up to the doctor.
Yes, that's the right approach. Yeah.
Okay. Fair. So I want to come to Dr. Khanna, family history. Like family history, for anybody adds a certain level of fear. You might not have it, but you're aware of your family history. Genetics plays what role in head and neck cancers?
Yeah, so in head and neck tumors, thyroid tumors basically, and especially few types of thyroid tumors do have a genetic predilection. And nowadays we have gene panels where we can just take 5 cc of blood and run them through different biomarkers of these tumors. And with almost 95 to 97% certainty, we can tell you that how much predilection that patient has to develop that tumor if some ancestral mom side or father side had the same, mostly for thyroid tumors. So in head and neck tumors, thyroid cancers, and especially differentiated and medullary carcinoma of the thyroid, these are the two types where there is a very, very strong 40 to 50% predilection to develop if anybody from your same genetic line has it before. So Thyroid cancers, oral cancers, no. Other cancers, no. They are mostly habitual cancers or environmentally issued cancers. But thyroid cancers, yes, especially differentiated thyroid cancers and medullary carcinoma of the thyroid. They have a very strong genetic predilection for that matter.
You made an interesting point. I'm not sure I understood, so I want a clarification on that. Somebody who has the genetics family history of
Thyroid cancer,
sorry, you're saying there is not a fixed percentage that he or she might have it. You still need to do that screening to understand whether it's going to be 20% or 80%. We can't assume a number.
Absolutely. So for example, very big celebrity, I'm going towards Sandip's side, a Hollywood actress got operated for her breast because of the genetic predilection to have a breast cancer. She removed both her breast and got it reconstructed. So same goes for thyroid. I have done 2-3 cases where we had to operate a 2-year-old boy from a very well-known family. And we did a thyroidectomy. I was called to Wadia because they wanted Wadia Hospital. So that was one of the few cases I have done because the whole family had a sequence of having that same tumor all through the generation, almost 3 generations.
Wow. Okay.
So thyroid cancers have a very, very strong, especially 2 types of thyroid cancers. One is a medullary carcinoma of the thyroid, and one is your differentiated thyroid, which includes your papillary carcinoma, follicular carcinoma, Hurtle cell carcinoma, all these. So they do have 30 to 40% predilection to have, but there is no guarantee or certainty that you will have or you will not have. But there are ways to find out. So we do something known as gene panel nowadays. I'm sure it is for breast also, where with almost 96 to 97% accuracy, you just give us your blood sample, we send it to the lab, and we can tell you how much chances, God forbid, your daughter or her daughter will have in the future to develop the same tumor.
I see. Dr. Bipte, what is the BRCA test?
Well, it's very important to continue this discussion ahead. I think the breast cancer also runs in the family very strong. So if I say 100 cancer, out of 15% are genetic one. 50 hereditary cancer. So it runs the family.
50.
15 is good number. So if we have a strong family history, say 2 or more member, if mother had breast cancer, grandmother had breast cancer, the probability of having breast cancer in the family is very, very high. And then these markers can be called as hereditary panel marker, breast marker, where we analyze genes which are responsible for having the breast cancer. Among the heading, the top list is a BRCA. It's called as BRCA1 and BRCA2. And there are other genes also. But among these breast cancer hereditary, this leads around 90%, they are the BRCA1 and BRCA2.
Okay.
And if same a blood test and we get the test done, the reports come in a 15 days time. But what next then? If it is positive, what will be done, right?
Yes.
You ask the question, how much percentage? So if it is BRCA positive, then it's a tune of 50 to 60% chance that it may have the breast cancer.
Okay.
And BRCA2 is around 40 to 50% till the age of 80.
I see.
After the age of 80, the risk goes down.
Okay.
So this is an active life. And then based on that, we plan the treatment then, how to go about that.
If somebody is genetically prone to this, and either we know the history or we can find out from tests, is screening different?
Yeah, absolutely. I always say it's a double-edged sword.
Okay.
To know, say for example, are we going to act on it? So if there's strong family history, then we get the test done and we check that the other family member, how much risk they have. Based on that, we plan whether to observe her, whether to do prophetic surgery or offer some treatment, medical treatment. That's an option we have.
Okay.
But if you offer someone test and you're not going to act on that, this lady will going to have always in the depression because she has a report which says you have BRCA, you're going to have breast cancer. So it has got repercussion.
Yes.
So it's not that one person job. We always involve genetic team, counselor.
I see. Okay.
So that's the main purpose of it. So once you find family history, we ask the family to meet a genetic counselor. They do the counseling, they brief them about, and then get the test done. And then we doctor meet them and we explain them. This is where it should go. It's not the off one to go get the test done and keep it in your pocket. No. Are you going to act on that? Then do it. It's a teamwork.
Fair. I can imagine. Let me come to the treatment side of things.
Right.
Once diagnosed, immediately patients start thinking in terms of surgery.
Right.
And there is a certain fear that comes with that. In head and neck cancers, what does typically treatment look like?
So head neck tumors are, depending on the subsite, treated in a very, very different way. Say, for example, a tumor in the nasopharynx, depending on its stage. So you first of all have to stage your tumors. So how do you do it? You do it clinically by examination, and you do it with imaging. So once you have staged your tumor, then you decide which is the best option to treat this patient so that he has a disease-free survival for 5 years. So for tumors, we usually look for 5 years and above.
Okay.
So once we have staged the tumor, for example, in nasopharynx, once you see an image, you see a mass in the nasopharynx, the second step is to go in and take up a tissue and confirm the diagnosis that this is what I'm looking at.
This is the biopsy.
This is the biopsy part. And once the biopsy comes positive, say in 3 to 4 days, we treat them according to the stage. So for nasopharynx, for example, stage 1, 2 tumors are treated with radiotherapy. We also look at the neck status because these tumors are, usually they metastasize to the nodes in the neck, both sides. So we also do the scans of the required imaging of the neck nodes so that the radiation oncologist can treat the neck also. So we usually use the same modality to treat the primary tumor and the area where the tumor has metastasized. It's never different modalities. So we'll not do a surgery for one area and where the other part, where the tumor has gone and we don't do surgery.
They'll be uniform.
Yeah, it will be uniform. But it's different for oral cavity. So oral cavity, again, you do a biopsy, you do the imaging. More often than not, 90 to 95% of the cases, we treat them with upfront surgery. And they are followed by a histopathology report. Once you send your sample of surgery to the lab, the doctor of pathology tells us what stage the tumor was. And there are some adverse factors we look at. And depending on those adverse factors, patient will require additional therapy, what we call it as adjuvant therapy.
Okay.
So there are 2 types of adjuvant therapy. There is something called as adjuvant radiotherapy and there is something called as adjuvant chemotherapy.
Okay.
Or there can be a combination of both, basically.
Yes.
So depending on the stage, you treat them, but that therapy is given only after 6 weeks once the patient has undergone a complete healing process from surgery or the operation, not before that. And then once you treat them, then you keep them on a strict follow-up. For the first year for head neck tumors, we give them 1 year, 1 month per year. I mean, one month they come to us, then we increase it to 2 months, then slowly third year we increase it to 3 months. So slowly we start increasing the time so that the patient is compatible and is comfortable also to visit us. Basically. So every subsite is treated in a very different way. Same is for oropharynx. So oropharyngeal tumors again are treated with radiotherapy first, depending on the stage. Or if they are very early, nowadays we do robotic surgery also for base of tongue tumors. So, so robotic surgery, because see, radiotherapy has got quite a bit of side effects also. Like your saliva is not formed, the mouth remains always dry. So some of my patients do ask me, Dr. Khanna, can you do robotics? Because if you can remove the tumor with a safety margin of say around 1 centimeter, he will mostly not require radiotherapy and chemotherapy or at least radiotherapy, because for a small tumor, you should not require chemo. So they can avoid radiotherapy if you can do something known as transoral robotic surgery. We call it TORS. So we can ultimately avoid radiotherapy from the front on, basically.
And which means patient recovers sooner.
Patient recovers faster. There are hardly any side effects. And mostly these tumors occur in areas which heal also very well. So because it's a very small tumors, there will be not much reconstruction required. So you don't need plastic surgery, flaps from your thigh or the arm or anywhere, because you need to cover these defects. So the defect is also very small. And because they are in inaccessible areas, so we need the robotic hands go in and we can control it with a joystick. And it just goes in and removes the tumor and we are out of it, basically.
Fair enough. Dr. Bipte, isn't that something also that's happening in breast cancer and surgery to cure that? We're talking robotic surgeries, we're talking endoscopic surgeries. I believe Zynova Shalby is one of the first in the country to have introduced that. How is that different from traditional surgery?
So basically, when you talk about cancer, it involves, Dr. Khanna has also always said, surgery, radiation, chemotherapy, it depends on what stage it's about, right? early cancer, we have different techniques. So endoscopic, robotic, they are techniques, right?
Hmm.
So they are the newer techniques which we implied in our surgery so that outcome is good. So I remember when I started the endoscopic and robotic 2 years back. And when you talk about a mastectomy, means remove the whole breast and the big scar. And when the lady wake up, she see big scar. They when they don't notice the no breast,
It's an
they
emotional
depression,
trauma.
emotional trauma. Today, with endoscopic and robotic, we can keep breast as intact as before. And we put a small incision, 3.5 centimeter incision, 3 to 4 centimeter in armpit area where the scar is. And when she get her from surgery, you see the breast is as same as before. We do reconstruct with implant, and that's the impact we have with the technology. So it's more of technology, precision, and the treatment. So whole purpose is going to get a great results and outcome in terms of the patient body image. That's very, very useful technology.
Fair.
Yeah.
Dr. Khanna, in head and neck tumors, aside from robotics, over the last 15, 20 years, how have treatments changed? How has efficacy changed?
Yeah, so right from the imaging to the results, aesthetic results, see, because head and neck tumors, the face is your mirror, basically.
Yeah.
Every whole world sees.
Yes.
So how, if you are removing a section of the jaw, how are you reconstructing it is also very important. If you're removing a jaw, if you're removing a, say, eyeball, how can you give the patient a prosthetic eyeball if you're removing? Because oncology is about removing things,
Yes,
unfortunately.
Yes.
So we should be able to reconstruct this area with almost 95 to 96% accuracy, which we do most of the times. But unfortunately, as I already told you, the patients come sometimes at a very advanced stage.
Yes.
And it is impossible to make them look as they were. Right? So they face a lot of social dilemma, and we also feel bad. But unfortunately, that is what it can be done. And trust me, we have fantastic plastic surgeons who work for hours. See, these surgeries are very, very complex
I would
operations.
imagine, yes.
So it takes usually for us like
Maybe 10
9 to
hours,
8
yeah.
hours
Oh,
to do one operation with reconstruction.
okay.
And then there is ICU rounds, and it's a lot of hard work by a huge number of professional surgeons. So things have changed. So we are able to give them better results. We have 3D models which we prepare before the surgery.
Yeah.
For example, the jaw can be printed on a machine, and we can pre-bend these plates which we use to take the leg bone from the leg, and then put these plates. But the bend of the plates is as accurate as how the
As
bend of the
efficient.
jaw is, basically.
Yeah,
Okay.
very true.
So literally the 3D print is
3D
an
printing.
exact
So
facsimile.
we mold our instruments according to 3D print. We even mold our grafts sometimes, the angles of the grafts according to those resection 3D prints.
Wow.
Plus, there is robotic surgery, which is doing very well in US. In India, unfortunately, insurance doesn't cover. Most of the insurances are not covering, but I'm sure in coming few years, and very few people are trained in TORs in India. So once people are trained more and insurances start covering, we can even reduce the number of scars. So nowadays, people are doing a thyroidectomy through a lip incision inside the mouth.
I see.
So you don't get a scar here in the lower neck. So you just open the lip and you put your instruments, and you can remove this gland from the mouth.
Wow.
So
okay.
and right, even from the axilla, like
The
how
armpit,
so armpit, you can go from here, and inside you go and remove the thyroid gland from the armpit.
Okay.
Yeah, but we have very few surgeons who are doing it, and this treatment for now is only reserved for patients,
small group of patients,
very small, who can afford it, because robots of good
Is
quality.
it even available here?
It is, of course.
Of course,
Okay.
yeah.
Okay.
It is available in many
good
big
center.
hospitals, good centers, but the cost of this surgery at this time is quite high, because the cost of the robot is extremely high. Extremely high.
I can imagine.
And the cost of training surgeons on those robots is very high, because there are very small number of training programs available right now in our own country, where we can go and train on the robots and get certified to operate patients. So we usually have to go to US or Europe or someplace other than India to get trained. So it costs a lot.
So Dr. Khanna, can I optimistically assume that it is at a higher cost now, but in time with more usage, would costs come down?
We expect so, because our country is really progressing fast, and we have a huge population. So with time, many good things will happen, and let's assume that say within a period of say 5 to 10 years, we should get this under control. Because see, as more and more centers start these programs, and you need to train more and more surgeons,
Yes.
the cost of the treatment should come down, ideally.
Fair.
So let's keep our fingers crossed and hope for the best.
Fair enough. Dr. Bipte, let me come to you. As technology improves, we're talking about in breast cancer, we're talking about targeted therapy, hormonal therapy, immunotherapy. And are these replacements to surgeries, or does one complement the other?
It's not replacement. It's a part of treatment. So when you talk about cancer treatment, it's a medical treatment, right? So surgery, yes, it's an integral part of treatment. So when the patient asks me, sir, मुझे खाली दवाई से हो जाएगा, surgery? No, surgery is needed, right? But as an adjunct part, this treatment like you said, targeted treatment, immunotherapy, there are the new therapies which helps to control the cancer at the best of it, and the disease can be free and we can have better outcome. So this treatment was not earlier available. Now it's available. We have with a precise treatment, precise targeting the cancer cell, precise making immunotherapy activated. So these are the wonderful drugs has come up, and the outcomes are much more better.
And side effects are lesser?
Side effects, absolutely. So just give an example. The patient asks, sir, ये target treatment क्या होती है? So for example, somebody had a bigger tumor, which is like a HER2 positive, and we give this injection before chemotherapy, the tumor may disappear. In 70-80% it disappears. For a surgeon, I just need to a small piece of tissue, right? With the target. With immunotherapy, in a triple negative breast cancer, when you give before surgery, the tumor may disappear in 70-80% cases. So that's a good. So we have less a smaller surgery, good response, and they do well. So that's a very precise, good treatment for cancer.
Excellent. So again, advancement of technology.
Absolutely.
Fair.
But it's not replacing the surgery.
Understood. Valid point, and I'm glad we clarified that. In head and neck tumors, Dr. Khanna, prognosis depends on what? Stage, timing, patient's age and health, and how does that change things?
So I believe the most important thing is prevention. Okay.
Fair?
If you can prevent a cancer, that's the best you can do.
For everywhere.
For every subtype of human body. But of course, the stage, as soon as the patient knows that I've been diagnosed of a tumor, there's nothing to get scared of. It's an early stage tumor.
True.
He should immediately seek help of a specialist,
expert,
a doctor who works only in that area, who does it day in, day out, who has done quite a bit of number of cases, who's known for his good work.
True.
And he should meet that doctor and get this problem solved. Because 90 to 95% cancers in the early stage, such as a T1 or a T2 for that matter, are almost 97% curable if treated early.
Fair.
True.
It's only when you keep them. Yeah.
Rightly said, because 30 to 40% people, they do come to us visiting someone else, had some biopsy somewhere with general surgeon or some other doctors, So it's a lag coming from a patient direct to the expert. I think by the whole purpose of this, the podcast is about to get the message to the audience that if you notice something, go to the expert of that field. That's what Dr. Khanna want to say. And for purpose of breast cancer also. So that will prevent all the hurdles, and patient will get the best treatment.
See, the human body is very complex. It has been thousands of years since people are trying to understand. And still we can't.
Yes.
Most of it.
Yes.
So when Dr. Sandip and me work in a specific area of a human body, we don't touch any other part of the body. We do it in day in, day out.
Yeah.
I mean, we do it in thousands, basically. We're doing since 15, 20 years the same job. We are very much assured by ourselves also that we can justify or cure a patient. And when we can't, we just directly upfront say no. It's not that we can cure everything. So many times patients do come to us referred by somebody in Rajasthan, in Bhopal or in UP or Bihar, when we say no, upfront no. Because we know that we don't want to put that patient in financial burden.
True.
Just trying to be heroic. I don't think so. Me and him are those kind of people.
No, there is hope and there is also practicality.
Exactly.
You have to find your balance.
Exactly. But you should not say something which you can't deliver. I am of very strong belief. So many patients we have to directly upfront say no, because he went to some guy and then he went to the other guy. The other guy said, no, this cannot be cancer. They go to Ayurvedic or other form of medicines, they try to take other herbs. I don't know what they take. And ultimately they waste a lot of time. So early stage tumor, which could have been caught at T1, now is T3 or T4.
Yes. So
Yeah,
this
so
is
he has-
Sometimes the treatment for particular illnesses has to be aggressive. One
Absolutely.
can't experiment.
and with this podcast, I need to explain to the audience also, because a lot of people go for alternative treatment cancer, which is not the scientific treatment. So somebody had breast lump and they just keep on putting, they go to Valsad, put some lap or it,
absolutely.
and they come a stage 4 cancer. Some they took Ayurvedic homeopathy and thinking that, there are the quacks sitting there and they say, oh, I'm going to cure the cancer. Which doesn't happen. They invest all money, and when they come in the advanced stage, doctor sab abhi acha kar do, which is impossible practically, right?
And you've come across these cases yourself?
Mostly, if I say 100 cancer, out of the 10, I'm saying 5 to 10 cases had been treated alternately and then come back to us.
Oh.
Is a high number.
At
So-
which point it has progressed.
It has progress, and definitely it is going to progress. It's not scientific treatment. So it's in a very scientific rational. When they notice something, they have to take with a scientific treatment.
Fair enough. Fair
Absolutely, we need to tell them, because it's an awareness, right? Because these people are not aware. And somebody, मेरे चाचा के घर में ऐसा हुआ था, मेरे सिस्टर के घर में ये हुआ था, उन्होंने कुछ लेप लगा दिया,
enough.
and they had put some rod, some steel rod, the iron rod to make the hot, and put on the tumor also. There are lot of things has happened, right?
Wow.
And till today, we do see this example in a society. So we have to break that taboo. The alternative treatment doesn't cure the cancer. And in very sadly to say, next to Tata, and there are the doctors who treats from the treatment from the patient from Tata, claiming that they're going to cure the cancer. And when they come to us, we feel so sad about that. They lost their money and the cancer progresses, which we don't want.
This
So-
is literally right next to the hospital
No,
that
the hospital,
specializes.
absolutely.
Yeah. And
So this is sad but truth.
Fair.
Yeah.
Your Zynova Shalby and Dr. Bipte yourself are helping that cause along in some way from a financial distress point
Absolutely.
of view. I believe
So,
you all
yeah,
are doing
absolutely. So this is very-
surgeries for free.
absolutely.
You said?
So we talk to the management and we say, those who can't afford, see, it's a service we need to provide, right? We cannot deny any patient that cost. There are trusts available, there are the funding available, there are patients available who won't donate. It's just matter of putting the dot together and we can help us. And as a doctor, Dr. Deepak will also agree, we do a lot of charity work. We never denied any patient for cost. Nahi hai, we arrange the cost and we do it.
Fair enough.
Yeah, and one more thing I like to add: the patients in our country have this prefixed mindset up to go to a very high volume center because they believe that the best treatment they will get. So we have very, very good institutions which started this journey towards curing cancer. But now there are hundreds of options available at the same price with same expertise. So what happens when you go to a very, very high volume center? You're given a very long date,
Yes.
right?
And-
So if
that giving the opportunity for the
cancer
exactly,
to grow.
where the
Oh.
treatment cost is almost match to match in any other hospital with the same hand,
Fair.
almost equivalent hand or even a better hand. So when you go at a stage 1 and you're given a date, say for example, after 4
2
months,
months,
6
yeah.
months, that stage 1 doesn't know that the hospital is so overworked as it is. So it will start growing to stage 2, stage 3, stage 4. So they have lost that critical time where they could have gone to Dr. Sandip or come to me and we could have settled that issue at the same economic level and saved them forever probably. So we face this quite often where, they are given extremely long dates just because they have that strong belief. But that's absolutely absurd,
I agree.
according to me.
So, Dr. Khanna, let me ask you this. What you're saying right now is from the perspective of choice or theoretical choice. But sometimes this comes from a sense of fear that we don't want to go to a hospital. Forget which hospital and which city.
This very, very, very commonly. Most of people, they don't go because of fear. And that's the way from early stage, it happened in COVID,
Tell me how the prognosis changes.
So absolutely.
Say
See,
from a breast cancer point of view.
a stage 1 cancer cured by 95%, right? Stage 2 around 80%, stage 3 less than 50%. So 50% going to come back. In COVID, what happened? All the women at home, nobody had screening tests, nobody went to the hospital. When the COVID out and when they came, we do see a lot of advanced cancer case. So
My God. Okay.
So this was, I do see a lot of cancer around 70, 80 years ladies in ICU. They don't examine themselves. They with an advanced ulcer, breast cancer ulcer, a big lump. So that's a tragedy. Neither they examine themselves, nobody time to have they examine themselves and delay in diagnosis. So
Yes.
all this add a worse prognosis of
No doubt.
treatment. Yeah, absolutely.
No doubt. Same applies for head and neck tumors and
Absolutely, almost same.
At least head and neck cancer, they are visible. At least,
See, that's what I mean. I told you before also. We can see these tumors. You can see a lump in the neck. You can see a lump below the chin. You can see something growing on your head or something coming on your eye, which is not going.
Yeah.
And it has been almost 4 weeks, 1 month, 2 months. But these patients need to understand that anybody, even I can get cancer. So there's no guarantee. But if my I have something which is not getting, and if that thing, the lump is not since my birth, then it's benign, of course. If something is there from my birth, a mark or a small lump, I can decide when I want it. It also needs to be taken out, but it's on my wish. But when you have something which was not there before, has suddenly come, has remained for 2 to 3 weeks, the symptoms are becoming worse, the pain is increasing, the swallowing is becoming difficult, it has started to bleed now, the pain intensity is becoming higher. This is not a normal lesion, or this is not a normal pathology. You need to see an expert, come ASAP and get it solved, because early you come, as he said, 95 to 97% success rate in T1, early stage,
Early
0
cancer,
to 2 centimeter tumors.
Fair.
Unfortunately, I see 70% of them coming at 4th, 3rd stage. That's the worst part.
That's the worst, yeah.
which is either from lack of knowledge or from a sense of
A
fear.
combination factor, you can say.
So we need to, for head neck tumors, we need to train our dentists. We need to train our OMFS surgeons, oral maxillofacial surgeons. We need to train our AYA workers right from the ground level.
Absolutely.
We should have multiple camps. As he said, we should train people to examine breast. We should go to schools, colleges. See, if you're really serious about it, this all needs to be done.
Yes.
And it needs to be done at a very, very serious note, where
Absolutely.
the objective is to get this number down.
Yes.
See, we are becoming a capital of diabetes. We are becoming a capital of hypertension, obesity, all diseases.
Now, this is not something you're born with. These are lifestyle
Absolutely.
diseases.
Absolutely, it's a lifestyle.
And still you find, you go to a Nukkar shop and people are enjoying the double fried stuff and again triple fried stuff and going 3 times a day to eat the same thing.
Yes.
And then, not even going for a normal checkup and saying, oh, how the hell I got heart attack.
Yeah. Fair.
So again, on top of that, I always say the celebrity makes the ad for this, like pan, gutkas, they should be banned, because for general population, they are the iconic,
Yes.
and that reflects. So everyone has to take a very hard step to prevent it.
Absolutely.
And we need some programs of de-addiction. We need them on a serious note.
Serious note, yeah.
In schools, colleges, Sandip can go, I can go, but there has to be a kind of a framework for these programs.
So the de-addiction is almost looked upon as a stigma in our country, let's say. But if it's more broad-based, if you start the concept of de-addiction from a younger age, make it part of education, then we know that if the trigger ever has to be pulled, it's not considered a stigma. Is that a fair assumption to make, that you speak to kids at a younger age and not worry about it? Once they have an addiction, then you worry about a de-addiction
So
clinic.
if I can give you an example, the maximum Chinese players who win Olympic medals are trained from the age of 4. They are not allowed to study. They're just, if you want to play tennis, they will play only tennis from the age of 4. They're given a racket. So you need to solve any problem, you need to work at the grassroots.
Absolutely.
With a very open and clear mind that I want to achieve this.
Yeah.
And there should be no distraction. There should be no financial restraints. We need to allocate more budget to our healthcare. India has unfortunately one of the least allocation of healthcare budgets.
Fair.
This is very unfortunate when we have to support such a huge population.
Yes.
So
Yeah, it's a budget thing and a population
of
thing. You're
course,
right.
because when you are the most populated country, ideally your percentage of allocation of budget should be higher than most of them.
True.
It's totally opposite in our country for that matter.
Okay.
And our government hospitals are overstretched, overcrowded. Our dedicated super specialty hospitals are almost, working to the uppermost limit. So as a patient who gets diagnosed of a tumor, whether it's a head and neck cancer or a GI cancer, what options he has? He has the option of private hospitals. So when these patients go to private hospitals, now private hospitals are not supported by government. They have to run the operations. They have to pay the salaries. They will charge you. Some acceptable, some probably think it's unacceptable. but the treatment then comes with a cost, which the patient has to bear. And there is no second thought. So we cannot say, oh, the hospital has taken so much money, because you are coming here for treatment, which has been delivered, but it will come at a cost because hospital here has to run also.
Fair. True. Absolutely. So I think from my learnings from this, that even though technology advance, it might come at a cost, but it is saving lives.
Yeah.
The step before that is literally prevention and early detection.
Absolutely.
And we need to be knowledgeable and less fearful about that.
Absolutely.
Absolutely. And you need to remove, you need to remove the stigmas. See, we start believing as a country about something and we just believe it blindly. That is not scientific.
Yeah. I think today's generation are much, much better. I quote a small example. Yesterday, I met a couple. His wife has breast cancer, and she started chemotherapy, and she started losing her hairs. So her husband also shave off all the hairs and do it together because they have small kid. And they say, "My mama, you have hair loss." But when he noticed that, oh, it's normal then. That empathy we need to make toward the cancer patient.
And empathy plays such a large part.
Yeah.
Fair. On that note, Dr. Bipte, Dr. Khanna, thank you so much for this. It's been insightful.
Pleasure.
There have been learnings. And thank you for taking out the time and sharing your knowledge with us.
Thank you so much. Hope it helps the audience to get this broke down the myths and facts of the breast cancer and the head and neck cancer. And this will take away, at least this conversation will take them when they have some symptom. I hope this conversation will make them helpful to treat cancer at early stage.
I believe it will.
Thank you so much.
Thank you very much.
Pleasure. Thank you very much.
Dr. Khanna, I want to address, let's say, a slightly touchy point. Somebody's been detected, somebody's been treated successfully and has been in remission, cancer-free for a period of time. And in some of those cases, we have to worry about relapses. In head and neck tumors, head and neck cancers, how often does that happen? Are there precautions one can take? What does one do?
So there are many factors which participate in a relapse or a recurrence, with what we call as. So recurrence can be in an area where the primary tumor was, or it can be away from that site, which is called as a distant metastasis. Or it can be in a node where you removed and in the neck and the node comes again. So it all depends on what stage you treated the patient.
True.
Did the patient completed the therapy after surgery, say radiation therapy? So for example, many of our patients, they just get fed up and they don't want to finish the whole part of 30 fractions of radiotherapy or 6 cycles of chemo. They will be like, okay, we'll take 3 and we are done with it. They get fed up. So was the patient compliant enough to finish the full treatment? And then whether the patient, most important, is coming for follow-ups. Because I can tell you, we lose almost 70 to 80% follow-ups, because once the patients are treated, they never come back and meet their surgeons or doctors. They feel, he has done a great job. There's no problem I have now. I'm living my life normally. But we lose a lot of records. And not only that, we cannot detect the second one, which has just come as a smaller one, which they can't understand. And because they miss it, it becomes a very big one. And then when they come to us, again, they have to go for a surgery or radiotherapy, or God forbid, if it's too big for me to remove and I cannot justify removing it, I'll send them for palliative treatment options such as palliative chemotherapy, and they're gone.
True.
So this is the issue we face mostly, most often than not.
Dr. Bipte, in breast cancer cases, if somebody has had breast cancer, then immediately she becomes high risk for a relapse. Is that true?
Not every patient. It depends on what stage they come to us.
Okay.
So early breast cancer, generally they do well. So if we say, if they take over 3 years, 5 years, then cured, right? A little bit stage 3 cancer, they are initial 2 years period is tough for them. And then as time passes, they're okay. But there are factors like a lymph node positivity. There are large tumor, some aggressive tumors. We always keep them a very short loop to follow up, because they do turn metastasis anyway. Again, Dr. Khanna rightly said, whether they completed treatment or not, that's another factor. If they completed, the risk goes down. And yesterday I saw a patient in clinic, and then she had surgery with me 3 years back. And then she didn't follow up in years. I say, where you gone? Radiation. So no, घर में कुछ financial issue था, so she didn't give okay. She's okay. She's fine, but without treatment. But she is at risk.
Yes.
So we have to categorically see this patient. Completion treatment versus not taken treatment is a big difference.
Fair. So there's something to be said for, you don't have complete control over a relapse, of course not.
Yeah.
But certainly completion of treatment, paying attention to the doctor's instructions,
Absolutely.
and more importantly, follow-ups, regular follow-ups.
I think it's a very, very important.
And the patient needs to understand that once he's a cancer patient, he's always a patient.
Yeah. So he's in remission.
He's in remission. He has been cured. He's disease-free. But he has to come and see his doctor at certain intervals, which scientifically have, been proven to save their lives. Because see, tumors, when they come back in breast, they come as a small nodule, some inflammation, which he can pick up early. Just do a FNAC, a needle biopsy, and say, okay, you know what? Your 1 centimeter small nodule, like tomorrow I'm doing a case. I've operated him 4 years back. Now he's come with a small nodule in the neck. So he thought it's a stitch, suture, which was kept. But we got a sonography done and it's a small nodule, lymph node, which has come. Small, around 7 millimeter. So we are removing it tomorrow. So surgery is hardly 20 minutes.
Oh, okay.
But if he would have not come, that would have become a 2 centimeter mass. I had to remove the whole skin. I had to get a flap going. It would have costed him 10 times more.
Absolutely.
So follow-ups are very, very important. So no cancer patient should believe, whether they feel good or bad about it, that they are cured forever. They should understand they're a patient. They can live their life normally. They need not to bother when people like us are there. But they need to understand that it's very serious for them to come and see us 3 monthly, 4 monthly, as per as their schedule, what we give them.
You'll figure out a schedule for
Absolutely.
them.
Every patient has a schedule. So for that matter, we increase the months as the, after third year, we call them after 6 months only.
Sure.
Then we call them once a year only. But first 2-3 years are very critical,
Fair.
Because if you lose a patient who has been treated by you, never know what happened to him.
Absolutely.
Early detection saves lives. Technology has evolved. Treatment outcomes are better. And hope is stronger than fear. A sincere thank you to both Dr. Deepak Khanna and Dr. Sandip Bipte for breaking down complex medical realities into clarity and reassurance. If this episode encourages even one person to get screened or consult a specialist, it has done its job. Thank you for watching. Take care, and we'll see you in the next episode. In the heart of Mumbai stands a name trusted by thousands. Over 1 lakh heart procedures, 200 plus years of combined experience. From diagnosis to recovery, your heart gets complete care under one roof. Because when it comes to your heart, experience isn't optional, it's everything. Zynova Shalby Hospitals. Experience you can trust, care that you deserve.